you've mentioned that you developed your own methodology and specifically CDI. And I know it's proprietary, but maybe could you kind of go a little background of just whatever you can kind of mention for the public about the process and kind of how it also builds off of like more traditional
Yep.
qualitative methodologies. Yeah.
Yeah. So that specifically is the thing that I started back when I was first joining Luna. And that was the IP that Luna gave back to me when the company closed. CDI, as Michael just said, stands for Community Driven Innovation. It is the concept that in health research, a lot of the times studies are predetermined. So an individual comes to a group of people and says, excuse me, I'm studying, sleep disturbances in children with epilepsy, and these are the questions I'm going to ask. We have to do that in health research because we need to IRB review what the human subject is going to go through. So we need to know the questions that are being asked, who they're being asked to, how they're going to be asked, how that person's going to be onboarded, how the results are going to be returned to them, all that information. It's really important, especially in certain communities. There have been really awful things that happened in the past. Like there was a study conducted by the VA on sexual trauma in veterans that they initiated by calling veterans directly and saying, since you've reported sexual trauma, we have selected you. And it was this loud voice that was on the phone. And so veterans that answered their phone on speakerphone because, hey, it's just a call from the VA, were suddenly having their entire family informed that they had sexual trauma while being a veteran and maybe had never told their families that before. Um, and so there was a whole swath of suicides after that happened.
Oh my God.
Um, so health research is very much required to know who are you talking to, how are you talking to them, and that sort of thing. Contacting pregnant women, maybe parts of their family don't know they're pregnant, all that sort of stuff. Um, so because of that structure, health research is boxed. And so boxed that most research has nothing to do with the actual priorities that people have. When you look at health research that was, okay, I was going to say is funded by the NIH, was funded by the NIH, not anymore, thanks to the modern environment, um, on, let's say, women, right? Uh, Almost none of that money is spent on priorities that, if you actually talk to women, are important. They're spending almost all of the money on breast cancer, which 20 years ago, women said was very important. These days, when you actually do UX research processes, and I can talk about CDI and how we implemented that into that, women say that irregular menstruation, the cost of taking care of their menstrual health, general breast health, not just um, breast cancer, all of that sort of stuff is actually higher in priority than breast cancer is because breast cancer has had so much research that it's actually much lower down on the scales these days. But nothing has been done to update that because everyone comes with their pre-decided questions and their studies that have already been approved, and they just keep doing the same stuff over and over again. So we developed CDI out of contextual interviews, um, something called Arrow's impossibility theorem, which basically stated that decision making was time bound. And we kind of invalidated that time bound nature of decision making and saying that we can actually break the time bound aspect of Arrow's impossibility theorem and start looking at decision making as an iterative thing over time. And then also incorporated things like card sorting and other UX aggregate decision making processes to make it so that we could have a living, breathing data set of priority that we could build the IRB approval off of. So rather than asking, we're going to ask these questions and telling the IRB of that, we said, hey, IRB, we're going to ask people what's important to them. We're going to evaluate their responses in this way, and then we are going to generate question sets based off of their priority structures this way, and then we're going to ask them the questions. So basically, we built a system for the participants to build their own studies. And then the IRB says, okay, we can't really say that you can't ask someone questions they have asked you to ask them.
Hmm.
And that gets around the boxed in nature of an IRB. As long as, of course, we do it in, we're not calling people on speakerphone. We're not emailing them the results of their own studies. We're doing it inside of a contained, identifiable, verifiable, authenticated platform, and all of that basic stuff. So we have, proper authentication. We've got proper identity verification. We don't email things over email. People have to log into the platform to get notifications. All those basic standard stuff, AES 256 encryption, all the things that is required. And then we can layer on top those UX research processes and give people the power to design their own studies. Um, and even some stuff that less UX, but these days also comes out of computational social choice, where we have things like quadratic voting and other mechanisms like that that are coming out of academia, that we have started implementing as additional processes on top of the CDI results, so that now the individuals can actually allocate money to fund their own studies that they designed themselves. So we're actually even getting out of the place of having a PI or a funder at all. The individuals are coming in and saying, "I'm giving $5 and I'd like you to study, the irregular menstruation from our women's health group." Or texting, right, was a big thing actually that came up in physical functioning for cancer patients. No one's studying texting, right? Fine motor motion. And these cancer patients who can't get out of bed, who are feeling very sick, also can't move their fingers very well. So they are cut off from all forms of communication for months on end. And no one's researching it, no one's studying it. So our cancer community actually brought that up as a need in their CDI and then funded studies on it themselves to try and build a better way to then be able to communicate, or at least study how to improve said communication.
Yeah, yeah, I think CDI is super cool, and I also think it's great in that it like provides this alternative source for a way to formulate hypotheses that are kind of like outside of the established literature, and for the reasons that you kind of already kind of touched on of like, for like on some cases, like yes, the established literature can be useful and some insightful, but there is a lot of institutional elements and other kind of factors that kind of create a little bit of a silo, versus just kind of asking people directly, just kind of like, hey, like what's important to you, and then like let's then create a more follow-up study based off of that. So yeah, no, I think that's
Yep.
great.